So what I'd like to do is, this isn't a comprehensive review of the evidence base for improving primary care, because that would require a lot longer than half an hour. So this is more of a tour of a few themes that I've come across in my work and that I've seen others report on that I think are relevant to today's discussion. So just by way of outlining the talk, I'm going to go through a few definitions and what we mean by the terms for the evidence base for primary care improvement, and present a conceptual framework that I think is useful for framing the evidence. I'm going to give you a tour of some representative studies, and then I'll leave you with a few concluding thoughts. And if there's time, I'll leave a little advice on navigating the medical home policy space. So first, on definitions. What do we mean by primary care? And I think when you enter this space, it's important to spend a little time on this because primary care has so many different definitions. Here, I'm going to say primary care is healthcare providers who are trying to fulfill 4 cardinal features of primary care, and these were defined by Barbara Starfield in her really magnificent body of work from Johns Hopkins. And these 4 functions are: first, contact care in the ambulatory care setting for the vast majority of new medical problems; coordinated care across settings of care, where the primary care provider will still be responsible for those; comprehensive care for the vast majority of health problems that patients have; and long-term person-focused care, meaning focusing on the same, preserving the relationship between the primary care provider and the patient over time, and making sure that the patient's values and preferences are included. Then we have primary care practices. I'll say this is the near environment for these providers who are providing primary care. Primary care practices can take a wide range of sizes. They don't all have to be in the traditional primary care specialties of family medicine, general internal medicine, pediatrics, family practice. They can occur in a wide variety of organizational and market contexts, ranging from small independent primary care practices to large integrated systems that may have subunits that are providing primary care. And they can serve a wide variety of different patient populations, and I think this is really important. Not all patient populations have the same needs of their primary care providers. So what do we mean by improving? I'm going to borrow the triple aim plus one, so a quadruple aim here, 4 dimensions. Better technical quality and outcomes of patient care. So this would be things like mortality, morbidity, as well as process measures of technical quality, like whether we're giving people the indicated services at the times they should be receiving them. Better patient experience. Some people call this patient satisfaction. When this is done in a scientifically rigorous way, it's usually a patient experience survey. And this is really, when you think about your own experiences with the healthcare system or those of your family members, you've probably encountered many problems and you think, well, this didn't really hurt us in a medical way, but it could have gone better. This is what we're trying to solve. Greater efficiency of care. So everybody here is probably familiar with increasing healthcare costs and the threat to our national economy that they pose. And the idea here is that by increasing efficiency, we can either improve the quality of care without increasing costs or decrease the cost without harming the quality of care. Finally, this is the 4th aim, not one of the triple aim goals, but I think a very important one, which is better professional satisfaction among primary care providers. We hear a lot about dissatisfaction and burnout among physicians, especially among primary care providers, with some concern about the pipeline drying up, and so that's why this is up here. So what do we mean by evidence? So this is a tour, as I mentioned, not an exhaustive review. I'm going to stick to peer-reviewed quantitative and qualitative research of a reasonably high quality. There's a lot of other kind of evidence out there, the gray literature, industry reports, and this isn't to be prejudiced against any of that kind of evidence. Sometimes it's actually very high quality. I just think for the sake of time, I'll stick to what's been peer-reviewed. So here's a conceptual model to keep in mind, and this is repurposing some work by a guy named Avidus Donabedian, who developed this conceptual model in the 1960s. And it's really been the conceptual model that underlies most of the work on measuring and improving the quality of care in healthcare. So he devised 3 levels of quality measures. At the top, you have measures of structure. These are the characteristics of individual providers. So, for example, their credentials, and of provider organizations. So this could be whether organizations have certain staffing configurations, whether they have internal reporting systems, whether they have protocols for how they handle patients who arrive in an order different than planned, and of course whether they have electronic health records, what kind of electronic health records, and what those features of the electronic health records are. Then you have processes of care. So now the patients get involved. These are care services delivered to patients. So an example here in the process measure of quality for, let's say, diabetics is whether a diabetic patient had his or her hemoglobin A1C tested within the appropriate interval. And the National Committee for Quality Assurance has developed a number of process measures that are both for chronic disease management, for acute care, and for screening for primary prevention. Then we have outcomes. This is what really matters. Structure and process only matter insofar as they contribute to better outcomes. So these are the ultimate effects on patient health, patient experience, efficiency of care, and the provider experience. Donna Bedian didn't include the provider experience in here, but I'm going to. So I want to make a point here that interventions to improve primary care are really in the structural realm. So it's not really possible to directly act on processes or outcomes. It's sort of like, economists sometimes joke about assuming a pizza. That's where you're jumping ahead of the ship, and you really need to get back to what are the ingredients to make the pizza, how long do we cook it, who's going to cook that pizza. That's all in the structural realm. This is also, I think, a really important thing to sort out in the medical home space, where we have visions of the medical home and then recipes for making a medical home in reality. The recipes are all structural. The vision, if you look at the joint principles, for example, of the patient-centered medical home, is a bit of a mishmash of structure, process, and outcomes. So there's some recipe and some hope for outcomes. So Donna Bedian made this point, and I think it's true of not just quality, but the other kinds of outcomes we're interested in here, which is that the evidence supports structural interventions only when they lead to better outcomes. So when we're looking at whether a structural intervention is successful, what we really care about at the end of the day is that bottom level, the outcomes. It's important to look at whether structure actually changed, but if the outcomes weren't affected, it would be hard to make an argument that it was a successful transformation. So I'm going to divide the evidence on categories of structural interventions into three pots. The first is studies of practices that have developed new structures de novo. So these are practices that on their own had some kind of problem, devised a solution to it, transformed their structure, and then had somebody, either themselves or somebody else, evaluate the ultimate effects on patient care. These tend to be highly customized, and by their very nature, they address the problems that the practices prioritize highly enough to commit their scarce resources towards solving. In the second category, we have studies of structural changes to practices that were designed or prescribed by somebody outside the practice. And this would describe currently a fair number of medical home interventions, some other research interventions that were designed for research purposes and that got willing practices to volunteer to join but didn't originate within the practices. These can be customized, but tend not to be quite as customized as those that actually originated within the practices. Then in the third category, there are studies of environmental or contextual factors that help or hinder the approaches in number one or number two. So for example, you could imagine primary care practices that are independent in a largely fee-for-service environment that incentivizes volume of care, generating RVUs, keeping the practice financially sustainable, versus the same kind of intervention going on in a practice within a highly organized capitated system that doesn't have the same kind of financial pressures. Even though the same structural intervention might be taking place, at least on paper, and as far as you can measure it, the outcomes might be different for the reasons of the environment. So here's one example of de novo interventions that this was a study I did during fellowship where we were trying to deduce how much individual structural capabilities might matter to a wide variety of quality indicators among around 300 Massachusetts primary care practices. So what's important about this was this study was done in 2007. So this was before meaningful use. This was really before anyone had heard of the medical home. So these were practices that at this time were doing this on their own. There was some pay for performance in the area, so that might have been one motivating factor, but any number of things could have been motivating these practices to adopt structural capabilities in a few domains that we surveyed them about. So one was assistance and reminders. Did they have a system in the practice for reminding patients to come in when care was due, to keep their appointments? We also asked about culture of quality. So this was whether they had meetings internally about the quality of care, where they were generating any kind of audit and feedback or reports back to primary care providers about how they were doing. We asked about access, whether they had interpreters for people who didn't speak English, whether they had night and weekend hours, at least some of the time. And we asked them about their electronic health records. And at the time this was done, only about 40% of the practices in the state had any kind of EHR. What we found was not that many significant relationships between these kinds of structural capabilities and the measures we were able to analyze. The one that seemed to be able to improve the most based on these structural capabilities was diabetes, and you see 3 plus signs there. EHRs had the broadest effect with improvements in both prevention and diabetes care, but you see depression and overuse, just really nothing actually relating in a statistically significant way with measures on those domains. And I think this speaks to the idea that an EHR and some of these other types of structural capabilities can have narrow effects. Even though you think about a practice changing structurally, thinking it's going to achieve, it's going to change all of its outcomes, the effect might be quite a bit more narrow than that. This is another example of a de novo quality improvement intervention that's gotten a lot of press and has been cited very commonly in support of the medical home as a model. This was a study done in the Group Health Cooperative, which was published in 2009, and then some updated results have come out since. What happened in this study was there was a practice within the Group Health Cooperative that was sort of their laboratory practice, and they were seeking to solve a problem, which was provider burnout within Group Health Cooperative among primary care providers. They had gone through a restructuring where they were trying to reprioritize primary care, and it had seemed to backfire in the mid-2000s. They had primary care providers leaving, not joining, and otherwise being unhappy. And so they took this one practice and said, we're going to fix this one practice no matter what it takes. And they put a big team together and really invested some major resources in this. And I'm not going to read everything on this, but I'm just going to mention a couple high points here. So they reduced the size of physician panels. So physicians were taking care of fewer patients, not more, under this new model. They also lengthened the time for standard office visits, and they carved out some protected, dedicated desktop medicine time with the idea that not all primary care needs to be delivered in person. Some can be delivered over the phone, over electronic media, and that's how they were able to serve these panels even despite the longer standard visits. They also made changes at the point of care, including some new features in their electronic health records. They made some changes to patient outreach, including things like automated outreach for abnormal test results and reminder letters to come in for appointments when they were needed. They also made some changes to management. And these are important. These have been widely replicated since this experiment. They did daily care team huddles. So this is the primary care physician, nurses, nurse practitioners, physician assistants, pharmacists, anybody else who might have care for the patients that they were going to see that day. They would get together and talk about the patients who were going to be seen and go through a plan for the day. One other thing, which is all the way down in the bottom right-hand corner here, is that these were salaried physicians. They took them off their productivity incentive. So even though this was a internally capitated system, it's prepaid, it's an integrated payer-provider, they took these physicians completely off their productivity bonuses. So this was a really fantastic result they got out of this. There were improvements on all 4 dimensions that I think are important by the second year of the intervention, so very rapidly. They had higher quality on a global composite of quality indicators that they calculated various ways. They had better patient experience on nearly all scales that they surveyed the patients about, using a couple of nice surveys. They had estimated savings of about $10 per patient per month. So it's not huge savings, but these were statistically significant. And remember, they improved quality, improved patient experience, so even if this cost nothing more to do, this is a good thing, but they actually had some savings. And they had less provider burnout, which was one of their main goals in the beginning. So a grand slam. However, this was in one practice within group health cooperative. You might ask, well, has this been replicated even within group health cooperative? We haven't seen any studies to suggest yet that that has been able to take place. And does this really look like more widespread medical home interventions that we often hear about? So I want to talk a little bit about medical homes now. This is in that second category of prescribed within practice interventions. So there are many medical home pilots within the United States. Most of these are still currently underway. Last count I heard was over 100 of these, including the federal pilots. These have some key components, and this is in the recipe for making that medical home. All of them include some kind of new resources for primary care practices. These fall into three general buckets: technical assistance, meaning coaching, education for the primary care practice staff. They might even have some learning collaboratives where the practices in the pilot can talk to each other about best practices. There's some kind of in-kind contribution in most cases. This could be the pilot buying and installing, let's say, a disease registry for practices that lack that. Sometimes the pilot will hire a nurse or a nurse practitioner to do disease coaching, and the practices won't bear the cost of that individual. And usually some kind of enhanced payment. Usually this is a per member, per month fee in addition to fee-for-service. Fee-for-service in general isn't touched in these pilots. So the practices are still under a productivity incentive at the margin. But the idea is to at least give them a little bit of a slush fund through that per member, per month fee that will enable them to make some investments they couldn't do otherwise. In exchange, the practices face some new requirements for participating in these pilots. They do need to transform, and they need to show that they transformed somehow. Usually this is through demonstrating medical homeness on some kind of recognition tool. The most commonly used one is the one from the National Committee for Quality Assurance, but there are others. Like the Joint Commission, for example, has an accreditation process for medical homes, which is particularly popular with federally qualified health centers. So here are some prescribed, some evidence on the medical homes. First, two recent rigorous evidence reviews reached the same conclusions about medical homes. These were published in 2012 and 2013. We had small to moderate improvements in some measures of technical quality and patient experience, and that was a moderate strength of evidence according to the ARC criteria. There was moderate improvement in provider experience, although that was a low strength of evidence. There was reduction in emergency department utilization, but not hospital utilization. That was a low quality of evidence. And there was scant evidence on costs, any quality of evidence, unfortunately. Now, these reviews included what I would call proto-medical home interventions, which started before the current wave of evaluations of medical homes began to report findings. And they preceded the typical criteria for demonstrating medical homeness. And in fact, a lot of these even preceded the joint principles of the medical home, which came out in 2007. So whether these are really a good foreshadowing of what the medical home can do in its current incarnation is a little bit unclear. So I want to present one evaluation that we just published last week, 2 weeks ago now, which was one of the earliest, largest medical home pilots in the U.S. in the sort of the current design of the medical home. This was the southeast region of the Pennsylvania Chronic Care Initiative. So this included 32 practices, 6 payers, 3 were commercial insurers, 3 were Medicaid managed care plans. Medicare was not involved at this time in the Pennsylvania Chronic Care Initiative, and it ran for 3 years between June 2008 and 2011. The key inputs were technical assistance from the state. They were teaching practices to apply the chronic care model. They focused the pilot mostly on diabetes for adults and asthma for children, and they gave the practices incentive payments, which I'll detail in more. I'll give you more detail on in the next slide. In exchange, they required the practices to obtain NCQA, that's the National Committee for Quality Assurance, medical home recognition at level 1 or higher within the first 12 months. There's 3 levels of medical home recognition from the NCQA, 1 being the lowest, 3 being the highest. And the practices needed to participate in learning collaboratives and report registry-based performance data. So here are the enhanced payments. This is what the practices got in order to fund this transformation. So each practice received $20,000 up front to invest in infrastructure, and most of the money came through a bonus that was contingent on receiving NCQA recognition. You can see that the bonuses were greater per PCP, or full-time equivalent PCP, for smaller practices, reasoning that as practices get larger, there might be economies of scale. And they're also larger when practices received level 3 versus level 1 NCQA recognition. The actual payments depended heavily on payer mix here, because Medicare wasn't in this. Those practices that had a lot of Medicare patients didn't have a lot of bonus money. But overall, it was a pretty decent amount of money. Average enhanced payment was $92,000 per FTE primary care provider, and there were actually some nurse practitioner-run clinics in here, so it wasn't all physicians, over the 3 years. So we looked at whether the practices transformed on structure, and they did, on a number of structural dimensions. So for example, the frequency with which practices transformed on quality, so frequent meetings about quality, they went from about 30% to just under 80% were having some kind of meetings about that over the course of the pilot. More than a 9-fold increase in the practices reporting having a registry of high-risk patients. About a tripling of the rate of outreach for hemoglobin A1C testing, and more than a doubling in electronic prescribing. So they really did target quality of care in their structural transformation. However, when we started to look at the processes and outcomes of care, sort of going down the Donny-Median model from that structure now to the process and outcomes, the findings were largely null. On quality, we saw statistically significant improvement on 1 of 11 measured process measures of diabetes care, and this was nephropathy monitoring, which is looking for early signs of kidney disease, so it can be treated in this diabetic population. There were non-significant trends towards improvement in 3 other diabetes measures, and no differences for measures of diabetes control, so whether the A1C was actually lower, or any of the screening measures we examined. There were no differences on measures of utilization, and we looked at rates of ambulatory care utilization, emergency department visits, and hospitalizations, and no statistically significant differences on costs, which isn't too surprising given what we saw in utilization. So our conclusions from this pilot were, this was a relatively large, relatively well-resourced multi-payer medical home pilot. Participating practices achieved structural transformation, and all of them got some level of NCQA recognition. About half were at level 3. However, the effects on patient care were limited. We saw some improvement on process measures of diabetes care and no changes on those other measures I mentioned. The results of this study were similar to those in other recent evaluations of medical home pilots that are looking at medical homes as they're currently defined. And these included pilots in New Jersey, Fiffield et al. Were in Connecticut, and Rosenthal led an evaluation of Rhode Island's attempt to do this as well. All these other studies were a little bit smaller, a little bit less of a time window was under observation, but largely consistent message coming out so far, unfortunately. So now I want to shift gears a little bit and talk about studies of environmental and contextual factors and how these may be affecting some of the things going on inside the practices. So there's a large number of ACO and medical neighborhood pilots underway currently. And these are, the idea here with an ACO, for those of you who aren't familiar with the term, this is an accountable care organization. This is an attempt to take large providers that may include primary care providers within them, and almost always do, and pay them differently within Medicare, but also within other payment systems. So if they previously were on fee-for-service, now they're being capitated or getting some kind of capitation light, like a shared savings model, where if they save some money, they get to split those efficiencies with the payer. They can pocket the difference as a bonus. Medical neighborhood pilots. Now these are pilots that are looking not only at primary care practices, but also at clusters of primary care practices and the associated hospitals and specialists that they might work with. Those are underway, and I think we're going to know a lot more about how well those work within the next 2 to 3 years, but it's too early to tell. In the meantime, we have some nice qualitative results that have been identified as facilitators and barriers to improvement. And the way these studies have been conducted is by looking within physician practices and getting a sense of what are the barriers to improvement that might be imposed from the external environment, and on the flip side, what are the facilitators to improvement that are coming from the external environment and helping these practices improve. So Chris Sinsky, who I know you're going to be hearing from, wrote a really nice report called Joy in Practice that was published last year. And she'll be speaking with you tomorrow, so I'm not going to review that one. However, I think it's pretty consistent with a report we wrote last year. This was the report that John alluded to earlier, which is called Factors Affecting Physician Professional Satisfaction and their Implications for Patient Care, Health Systems, and Health Policy, which was available for free download at RAND's website. And we did this on behalf of the AMA. So the design of this study was primarily qualitative. We collected data from 30 practices in 6 states. Wisconsin was actually one of the states. And we tried to get a variety of different practice sizes, specialties, and ownership models. We conducted over 200 qualitative interviews. This allowed this kind of in-depth data collection allowed us to allow detection of unanticipated findings beyond what you might get from sort of a closed-ended survey. And we had some quantitative surveys to further explore the qualitative results. I should mention, because this is a conference about primary care, that we included a number of multi-specialty and specialty-only practices in the study as well. What I'm about to show you in terms of results was reported by everybody, though, not just primary care. So the first thing we noted was that perceived quality of care is closely related to professional satisfaction. So being able to provide high-quality care was satisfying to physicians. And the chief thing we heard about professional dissatisfaction was, at the end of the day, I don't think I did as well as I could have because X, Y, and Z prevented me. And this is where we started to get into burnout among physicians. We saw similar results in our quantitative analysis. So the significant predictors of better satisfaction was feeling like it's possible to provide high-quality care. And the practice trying out new ideas to improve quality, especially when the physicians, we had a survey question in there saying, when I have an idea for improving quality in this practice, the practice leadership listens to me and actually tries it out. If they said no to that, that was a significant predictor of overall burnout and lack of professional satisfaction. Also, receiving useful feedback about the quality of care was a big satisfier for physicians. Feeling overwhelmed by patient needs was a predictor of significantly worse overall professional satisfaction. So I say that as context for the next thing, which is really about the system. So practices, we view physicians as canaries in the coal mine for quality based on this result. So sources of dissatisfaction can be threats to quality, and I think it's important to investigate and verify what physicians and other providers in the primary care practice are saying. The solutions are probably not only important to the providers themselves, but also to the patients they serve. And for sure, practices need more slack to improve and even maintain performance. This was especially true in the primary care practices. We heard a lot about not having enough time with patients, not being able to invest anything or especially any time in practice improvement just because of the need to meet overhead and keep the practice functioning as a business. So the other main finding in the report was which concerned electronic health records. And here we found both positive and negative effects. The reason I think this is important to point out in the category of environmental influences on practice improvement is that we're now in the era of meaningful use and a pretty powerful mandate for all primary care practices and all physician practices in general to adopt electronic health records. So they improved professional satisfaction in 3 main ways, and these aren't surprising given what I just said about the association between perceived quality and professional satisfaction. So better access to patient data within a single EHR, cited as very important to professional satisfaction. It also improved some aspects of quality, so physicians would say, well, now I know exactly how many of my diabetics are out of control and I can target those individuals. I really like doing that. And there was certainly better communication within the practice. So an example here from an orthopedic surgeon, although we've heard similar things from primary care providers. This was an orthopedic surgeon in a large group, with hundreds of docs, and able to look at anybody's note anytime on any patient that I'm interested in or who has seen me for something. I think the EHR just erases a lot of potential for medical errors and so forth because everything is clearly documented. And of course, there's not the handwriting issue. On the flip side, and this is where I think we were surprised and why I'm really glad we did a qualitative study, we saw some significant negative effects of EHRs within these practices, at least as described by the physicians and those who worked with them. We saw worries about time-consuming data entry, user interfaces that didn't match clinical workflow, interference with face-to-face patient care, a lack of health information exchange between EHRs, which was a real disappointment for physicians. They sort of bought into this, again, in this idea that quality is going to improve, that they could be able to see records from everywhere, and that was a big selling point, and more than the financial bonuses. And when that failed to come to fruition, major disappointment. Information overload. Some of these were more expensive than anticipated, especially for smaller practices, threatening the practice as a business. Inefficient and less fulfilling work content for physicians in particular. And I think particularly troublesome template-based notes, which are a solution to some of the problems above, at least for the person who's writing the note, being a real problem for everyone who reads the note because it degrades the quality of clinical documentation. I'm going to just give you a couple of quotes here to illustrate these points. As a primary care physician, what's really happened since going on the EHR is that I've taken on the responsibility of transcription as well as billing, in addition to other things. It's given me more mundane clerk-like duties to do. The derogatory term, I guess, in residency was scut work, and that's what the EHR has done. So this is someone who very dissatisfied with his or her EHR. And I think relevant to this conference, when you think about engineering processes, this is probably a red flag that needs to be chased down. Here's another example about usability. Every screen's got 50 different things, and they're changing. It slows me down. I do a lot of my charting at night. This is a very common report from physicians. They like being able to do charting at night, except that they have to do it. And they used to have to do it in the practice. They'd stay a little bit later, but now they have to do it at home. Now you're getting ahead of me. The problem is I'm spending more hours doing it than I would have before. You have dragon you have to be careful of because they just dictated a patient's prostate is bothering him, and it turned out a patient's prostitute is bothering him. You really have to read that carefully because they can end up going to court with that stuff. So, humorous example, not always humorous, about the transcription function. This is a cardiologist now talking about receiving templated notes. As with all electronic medical records, I greatly dislike the document that's produced. We have been forced to abandon a way of documentation that was always very effective and very succinct, so maybe some rose-colored glasses, hard to say. These documents are unreadable because you've got to skim through them really quickly and say, where's the meat here? You hear about reams of information being regurgitated. A lot of this is being faxed between practices rather than electronically communicated. So it's very hard for physicians who are receiving these notes to find the signal for all the noise. So putting it all together, between the three categories, got a couple slides here. I think the origins of improvement efforts may be important to their effectiveness. Efforts originating within practices may be the likeliest to succeed on all desired dimensions. And I think the example there to really hold out, and this is just one example, is the group health cooperative experiment, where they were responding to a local need, they poured resources into it, and they really achieved the results they were looking for. But most practices probably need resources, like group health cooperative had. Most practices don't have those. They need customized guidance, and they need enough organizational slack to do meaningful change. In primary care, creating slack probably means a substantial departure from fee-for-service payment, or more precisely, from incentives that are linked very strongly to productivity, with productivity being measured the usual way: number of patients seen, number of IVUs generated. More prescriptive, uniformly applied approaches haven't done so well so far, possibly for the following reasons. They reach or exceed the limits of what can be pre-specified, given the heterogeneity of primary care practice. They limit, potentially, practices' ability to customize solutions to local needs. And they may actually degrade performance when changes that are poorly designed or mismatched to patients' pre-intervention states are pushed out with strong incentives. So I'd be happy to take some questions now. Thanks.